Hello, everyone, and welcome to CancerSpeak, the official podcast of Cancer, a journal of the American Cancer Society. My name is Tyler Kratzer, the host of today's episode, and I'm a researcher at the American Cancer Society. Today, I'm happy to discuss a recent report that I was the lead author of, and I'm very happy to be joined by some of my co-authors, Jessica Starr, Dr. Scout, and Dr. Monique Gary. This report is the first to provide a comprehensive analysis of national information on the prevalence of cancer risk factors and screening in LGBTQ+ populations. Thank you, everyone, for taking the time to be here today. And Jessica, would you like to introduce yourself?
Hi, thank you, Tyler, for that wonderful description and introduction. My name is Jessica Starr. I am also a researcher at the American Cancer Society, and I was really honored to be a co-author on this paper. I primarily focused on the data side and running some of the analysis.
Dr. Scout, would you like to introduce yourself?
Sure. Hi, I'm Dr. Scout, the Executive Director of the National LGBTQI+ Cancer Network. I was also happy to be a co-author. I think I primarily focused on looking at some of the big picture items and making sure we were catching the important things to lay out there.
And Dr. Gary, would you like to introduce yourself?
I'm Monique Gary. I am a practicing breast surgical oncologist in Pennsylvania, part of the Penn Cancer Network, and I'm an adjunct associate professor for health equity at the Dartmouth Geisel School of Medicine. So I'm just thrilled to be here and chat with all of you about this really important work.
Thank you all. So kind of the two big things that this report has is an analysis of cancer risk factor and screening prevalence by sexual orientation and gender identity. And the second one is a literature review of cancer incidence and barriers to care for LGBTQ+ cancer patients. We really wanted to describe the disparities and discuss the challenges that LGBT individuals face in accessing quality healthcare. And two of the big ones that we found were discrimination in healthcare settings and shortfalls in provider knowledge of unique medical needs of LGBT patients. Jessica, could you describe some of the disparities we found in cancer risk factors and screening?
Definitely. So some of the disparities that we found in risk factors and screening were primarily in terms of thinking about risk factors. So a lot of the findings we found were particularly about obesity or excess body weight prevalence in both bisexual and gay lesbian persons. We also found higher rates of current tobacco usage as well by sexual identity. And in addition to that, I believe we also found higher alcohol usage in specifically bisexual persons compared to heterosexual persons. When thinking about cancer screening specifically, correct me if I speak a little bit wrong about it too, Tyler, we didn't find as many significant associations, but that may or may not have been related to the fact that these sample sizes that were available to us in the data set, particularly when looking at transgender persons, were quite low in terms of the sample size of who was available in answering these questions that we're looking at. One of the things that I think will be particularly interesting as we're moving forward is seeing the fact that I believe the numbers from another literature article were that something like 3% of people who are considered like the boomer generation identified as gay, lesbian, bisexual, or transgender, I believe it was, whereas 21% of Generation Z, so I know it's starts in 1997. I can't remember where exactly it goes to, but a younger generation is now entering kind of this group, or is going to in the next couple of years start entering this group when thinking about eligibility for certain cervical cancer screening, and even later looking at colorectal and prostate and breast cancer screening.
Yeah, and even with the sample size concerns, there were significant disparities for especially transgender men in cervical cancer screening and colorectal cancer screening. We saw significantly lower rates of screening among transgender men compared to cisgender men, and compared to transgender women, cisgender women, and non-binary individuals as well. I believe it was about 46% of transgender men who were eligible for screening were screened, compared to about 60% of the other groups. Dr. Scout, I've got a question for you. Would you mind describing some of the major barriers that LGBTQ populations face when seeking care after a cancer diagnosis?
Yeah, sure. I'd be happy to. And as a trans guy, I'm very much aware that I think one of the things that you're both bringing up here that is just showing how this is potentially the tip of the iceberg is that, as you can see in this study, there's a lot of places where it says this suggests or one study reports kind of thing. So we did an excellent job, I think, of collecting as much available evidence as possible. But this really is a game of very little data about a population that is growing very quickly and has a significant number of barriers to care. So what we're really seeing is that across the cancer trajectory, when it comes to even pre-survivorship and people who are getting vaccines against HPV or trying to keep themselves as healthy as possible, that our communities are at a significant disadvantage. And one of the things that's a reality about this is we have to understand that there's been 515 anti-queer and mostly anti-trans state pieces of legislation just introduced in 2024 alone. And also with ACS, we have done some work on interviewing some of those people. And really what we found is the unfortunate truth is it's kind of declared a little bit of open season on us related to healthcare very broadly. So we are less likely to get those screenings that you talk about. And I'm pretty sure as those data get more robust, we're going to find out that it applies to much more of the population than the few groups that we know now. But then that means, of course, that we find cancer later. And this whole concept of, unfortunately, a lot of this legislative wave emboldening the healthcare provider population, including like 20% of the country, as is pointed out in the report, is currently covered by laws that allow providers just to say, you know, my religion objects to you, so I'm not going to treat you. And also the fact that these laws are being expanded to include conscientious objection as well. So people can just say, I don't agree with you, so I'm not going to treat you. Unfortunately means that for us, one of our biggest issues is we even think about we're going to get more likely to get diagnosed later, have fewer treatment options. But as we get into cancer treatment, that means we're suddenly going to be frequent flyers of the healthcare system. And we can't figure out right now who is safe and who isn't safe to go to. So, we hear again and again with stories of people that they think they're going into care that's good. But, we have trans people where they're misgendered 9 times before someone finally in the 10th time actually uses the right pronoun, the right name. And that's every time they go get a chemo appointment. So there's just so many ways that the healthcare system is either building trust or not building trust with us. And unfortunately, right now, there's more of a preponderance of being moot about the point and thus not building trust, or actively doing things that continue to erode that trust with us. So I think one of our biggest issues as we go through treatment is who can we trust and do we feel comfortable with them? There was another study, it's also put in the report, showing that we were almost twice as likely not to follow doctor-advised treatments. This was specific to breast and chest cancer, but I suspect it applies to all, and that is medical mistrust in action. So I really think it's this concept that the medical communities have not done anything to more aggressively tell us we're safe for the places that are safe, that creates one of our biggest ongoing barriers as we go through cancer treatment.
Oh, absolutely. I mean, I totally agree. As Scout said, bias is pervasive and it's being supported by legislation. And this undermines our medical education in the health equity space and our efforts to get healthcare providers to identify with and acknowledge and really support a community that is clearly at risk. The consequence of the erosion of trust, as previously mentioned, is lack of referrals for basic cancer screening, lack of support resources to support those screenings. And this gets interpreted as a lack of adherence by a community, as this report attests to significant barriers to access. It spells out the fact that a community, and I mean the medical community, needs to recognize that we can't afford to stick our heads in the sand. We can't afford not to do the research, because the overarching conclusion from all these studies, especially as it relates to the BIPOC community, is that more data is needed, more research is needed. And where are these research opportunities and the funding for these opportunities? Who are the researchers who are going to conduct the research and make sure that we're offering equitable care and that our trainees are adequately trained to provide the care? So for me, I think this is a huge clarion call and an opportunity to intervene early, because when you look at the modifiable risk factors like smoking, no leisurely physical activity, alcohol consumption, that's really where our primary care community needs to step in. But if there's no trust, these things just aren't happening.
So those are very, very good points. I think it kind of leads us naturally into one of the things that we discuss in the report, which is that among medical students, about 95% of medical students are comfortable treating lesbian, gay, and bisexual individuals, but only 70% are comfortable with treating trans individuals. And only 1 in 4 are comfortable in their knowledge of the health needs of transgender patients. I think among current oncologists at National Cancer Institute designated comprehensive cancer centers, less than 40% of those current oncologists were confident in the health needs of their transgender patients. There's quantifiable disparities here, especially for transgender patients, but also for lesbian, gay, and bisexual patients. Dr. Scout, I know that the LGBT Cancer Network works with healthcare facilities to educate them on the care needs of LGBT patients. Can you talk about a little bit about those resources that are available?
Yeah, absolutely. And to put a finer point on some of what you said, we've been actually assessing NCI designated cancer centers for the last couple of years on what we can find on their web about Welcome. And the truth is that at least about a fifth of them, if not more, depending on what metrics you use, are absolutely saying nothing at all. And again, in this legislative environment particularly, nothing is not it's very loud. And the bane of our existence is whenever we hear what's still being said, we treat everybody the same, because that's kind of like the analogous statement of, I don't see race. It is a failure to understand that the people coming to your table are coming from a different background, and that we need different types of assurances in order to get equitable care. But nicely, there are resources related to this. We talked about in a report like Welcoming Spaces is a 5 different part training program that's online, enduring, and free. You can get it at our website, and that can be for anybody from your frontline staff all the way up to your specialty providers. But also, we're happy to say that after working with 7 of the NCI designated cancer centers specifically to build their welcome over the last year, we put together a toolkit based upon the lessons from that, and we're launching that this month. So we have a welcoming healthcare provider toolkit that is coming out basically by the end of Pride Month here. And we often find that it's not that providers are not well-meaning. They really want to change, but they're kind of overwhelmed and don't know where to find those resources. So it's one of those places where we really encourage not just the providers, but the actual patients to encourage your doctor. If you don't see anything about it being LGBTQ plus welcoming in a doctor's office, ask them why and encourage them to get more training and more resources, because this kind of willful blindness to this issue right now is unfortunately feeding a health disparity, particularly in this hostile legislative environment.
Absolutely. Absolutely. One of the things that really impacts my work as a surveillance researcher is a lot of healthcare facilities don't routinely collect data on sexual orientation and gender identity. You don't collect that data in the first place. It's had a negative effect on patient care because you aren't well aware of the needs of your patient. And 2, it impacts cancer surveillance research, right? Because we rely on population-based cancer statistics for most populations that we report on. However, when this data is not collected, then cancer registries and other entities that collect electronic health records are unable to accurately report information. So one major omission and one limitation of this report is that we don't show population-based cancer incidence and mortality for LGBT population groups, which we would really like to be able to do. So hopefully in the future, this data will be collected more regularly. One thing I want to go back to, Dr. Gary, that you mentioned was the need for further research. One research gap at the moment is there's a lack of evidence investigating gender-affirming care and later cancer prevention and treatment. Do you have any thoughts on research opportunities to fill that gap?
I think that the Society of Breast Surgeons is beginning to look at some of this. And I was just messaging offline about the fact that I don't see that welcoming curriculum really at the society level for all of our medical societies, but I do see us creating task forces, working groups, and subcommittees to start addressing this and partnering with other surgical societies to conduct the practice-changing research that we needed. And I'm really excited about the research that's going to come out of these sort of cross-society cohorts where we're starting to ask these questions and look at the data. So I think there's more to come on this story. But I will say that the Society of Breast Surgeons in particular, we really are working to try to fill in some of these gaps. I think it would be impactful and really important to parallel that, though, with education for our members. And I think we can do that across the continuum with medical societies to really offer programming like Welcoming Spaces. Because before the research can happen, we need to make sure that our clinicians are feeling comfortable to ask the questions and assess even basic demographic data in order to get into the research that we're going to do. I'd really like to see parallel efforts in that regard. But I think we're getting to the point of recognizing that not only must the research be done, but we are the ones to do it.
Thank you very much. From the American Cancer Society standpoint, we try to work to help address disparities and improve outcomes for LGBT patients with cancer, really through 3-pronged approach. We have advocacy, which is through ACS CAN, outreach. We partner with groups like the National LGBT Cancer Network and Dr. Scout to help fund and expand education, training, advocacy, and tobacco use reduction opportunities, and also through research, performing research like this report. Hopefully in the future be able to report on population-based statistics for LGBTQ plus populations. We also participate in Pride events every year. We participated in 65 in 2023, and I hope to have even more work on the ACS side moving forward in this area. Dr. Scout, Dr. Gary, is there anything that you want to add?
I would like to say that on the point of data collection, I think it's hard to sometimes explain to people, why is it we're asking if you're LGBTQI as you go into the doctor, right? And why are we sometimes asking if you go in for like a sprained ankle or something like that? But if we work on the other side of the equation, that's exactly how we get information. It's attached to your health record, and if it's attached to enough people's health records, then that's how you get information in cancer registries. And that's how our researchers are able to go back to NCI and say, this is a problem that needs attention, and these are of the data that we already have about the population. Right now, the fact that it's still optional in providers' offices to ask for that information in the first place is one of the biggest problems currently in trying to assess the scope of cancer impact and to create those interventions that are going to get rid of the health disparities in cancer for us. So the next time you're asked if you're queer at the doctor, thank them, because they're part of getting rid of our health disparities.
Yeah, so I just wanted to follow up a little bit too on the prevention side. I mean, we see that a lot in terms of the data that we were working with here, in terms of like how the questions were asked and what questions were available in terms of asking about sex and determining that between gender, and then also asking about transgender status. And particularly when we're thinking about cancer screening, a lot of when we're looking at cancer screening and cancer screening rates were informed by guidelines. The main one that's primarily used is the United States Preventive Services Task Force. There's also the American Cancer Society guidelines, and there's several other guidelines that are in place. But one of the problems becomes with that is that a lot of those guidelines are more so specifically assuming people have a sex and a gender that align with each other. Just recently, the USPSTF released new breast cancer screening guidelines, I think within the last month or 2 months. It seemed to be one of the first times that they even specifically mentioned transgender men getting breast cancer screening. Even within that, we're still seeing the question, too, of looking at this data and sharing some of the research that was done in the literature review here. We're seeing the fact that, I'm using breast cancer screening as an example, for transgender women, there isn't specifically a guideline, the USPSTF guideline for transgender women be receiving breast cancer screening related to whether they're receiving like hormone replacement therapy, or they've gotten top surgery, or any kind of gender affirming care that they've received, how that's going to impact their cancer screening, because it does. And we don't currently, and specifically too, since the USPSTF is tied to insurance coverage, that is what's being covered when we're thinking about these screenings. And so without that coverage, people aren't going to go in and get screened. And that's a big problem that we're seeing, is there are people who should be getting screened based off of what gender affirming care or what status they are in their transition, that should be getting this care, but they're not, because they're not covered based off of these guidelines.
Oh boy, and that's a perfect segue to really talk about breast, because I have my own opinions about the U.S. Preventive Task Force and the guidelines and how there's some serious gaps in those guidelines. But the bottom line is that there continues to be category I, insufficient evidence to suggest that we should carve out special and unique screening considerations for these at-risk populations. Insufficient evidence to suggest that Black women should be screened earlier. Insufficient evidence. And I think as we continue to hear that, we really need all hands on deck. And it's an opportunity for us to look at the resources that are available and acknowledge those gaps in our own knowledge. As you say, it's enough. We're in 2024, and it's enough of insufficient evidence. And we need to do this research, ask the questions, and get involved, and get informed to really educate our medical societies from the standpoint of the clinicians, at least, and look to build community partnerships to begin to bridge trust. We're in the era of precision oncology, and we continue to see certain communities that are left behind. BIPOC intersecting communities, our trans communities, and we've got to do a better job all around of collecting the data to inform the research and inform the guidelines. So I'm really excited about the opportunity, and I'm hopeful that we're going to rise to the occasion.
And just to build on something that we were kind of talking about there related to the data collection, another big issue is lack of inclusion in clinical trials for us right now. The reason why that's big in cancer is because clinical trials are rapidly becoming standard of care. So if you're not collecting, data on us in clinical trials and actively making clinical trials safer for us, so we even want to get into a place where we might be seeing more physicians where we don't know for sure if they can be trusted to respect us and treat us with dignity. If that's not happening, then unfortunately, it's another area where we're really feeding the inequalities and the disparities. So I agree with Dr. Mo. This is really all hands on deck. This is easy to fix. It just requires will, effort, and some determination from healthcare providers, from policymakers, from researchers, because these disparities should not exist, don't need to exist. They're a legacy of a time before. We can get rid of them.
Absolutely. That's a very, very good point, that these disparities can be beat. They can be beat back, and they don't need to exist the way that they do. Frankly, from the cancer research side, we don't know the extent of the disparities in cancer incidence, cancer survival, cancer mortality. And the hope is that moving forward, we can quantify those disparities. And because quantifying disparities when it comes to chronic health conditions like cancer is very powerful. It's a very powerful tool to use for advocacy and for targeted intervention moving forward. We can look at these disparities in cancer risk factors and screening prevalence. For example, bisexual women are twice as likely to smoke cigarettes compared to heterosexual women. We know that cigarette smoking increases the risk of lung cancer by 25-fold compared to being a non-smoker. We can look at that and we can say, okay, bisexual women are probably at an increased risk of lung cancer. But we don't have the data to back that up and say, hey, this is the disparity in lung cancer that we're seeing. And I think that is a really important step moving forward as well.
If I can also say, if you're in the health field and you're looking for some really easy steps for how to not be part of the problem, but be part of the solution, one of the first and most powerful ones is put a pronoun sticker or pin on your lanyard so that we can understand that you recognize the disparities and don't want to continue them. But then if you're an organization, see if you can add queer engaged, queer trained health system navigators. We've got lots of evidence about those make a world of difference to us because they help us understand and get through your institution to the safer spaces and stay away from the places where we might not have as good of an experience. So again, not rocket science. This can happen, and everybody listening can be a part of the solution.
Thank you, everybody, so much for being here today and discussing this really important topic. As the lead author on this report, I also want to thank you so much because without your expertise, it would not be nearly as great of a report as it is. I very much so leaned on all three of you to make this report impactful and well-researched and well-written, and I really, really appreciate that. That's all the time that we have for this episode of CancerSpeak. I encourage all those listening to read the American Cancer Society report, Cancer in People Who Identify as Lesbian, Gay, Bisexual, Transgender, Queer, or Gender-nonconforming. It is now available in Cancer. We will include a link in the show notes.